Gemma, will you take notes when we do the roll call just so we are mindful of who's here?
Yeah, sure.
Awesome.
Anna Garcia, the one we've already met.
Well, I'm showing that it is officially 3 o'clock, and so we want to just be mindful of everybody's time. So thank you for coming to the Chamber's webinars and information sessions. Today's video or Zoom call is with the group from KVH. Thank you for joining us today. I would like to do just a roll call, if you wouldn't mind, before we do introductions of those from the KVH team. Would you mind if I did that?
Go for it.
Okay, so let's do roll call, and I'll just call the name that's on the viewing, just so if you can say your name and who you're representing, that would be great for us today. And I'm going to skip over staff, but there's Gemma and Madison Ford, and they are staff of the Kittitas County Chamber of Commerce. And the next gentleman, I might butcher this name, but Marachi.
That's a pretty good butchering. That's not bad.
Okay.
It's actually pronounced Marash. And yeah, I'm Ed Marash. I'm the administrator at Prestige Post-Acute and Rehab.
Thank you. Carly Jensen.
Yes, hello. This is Carly Jensen with Heritage Bank.
Welcome. Kimberly.
Yes, hi, I'm here with Herbert Snowden Insurance.
Oh, hi, Kim. How are you?
I'm good, Amy. Good to see you.
Yeah, it's been a long time.
Yes, it has.
And I'm going to say Hochter.
Hi, this is Paula Hochter from Hope Source. I'm the Transportation Senior Manager.
Hi, Paula. Lyons.
Andrew Lyons with Hope Source as well.
Thank you. Terry Clark.
Hi, this is Terry Clark. I'm one of the KVH commissioners representing the community to make sure that you're all safe and well.
Well, thank you for joining us. Arim.
This is Ari. I'm from Hope Source again.
Thank you. Matt Bender.
Hi there, this is Matt and Christina Bender from Pearl Care Dental.
Thank you. Shelley Burton.
Hi, Shelley Burton with Wholesale Networks, formerly Knoll Communications.
Oh, hi, Shelley.
Hi.
Leslie.
Yes, hi, it's Leslie Thurston. I'm the director of the Washington State Horse Park.
And Mandy Weed.
Mandy is with KVH.
Okay. And Molly Jones, Kirchner, right?
Yes, Kirchner. Hi, I'm Molly. I'm the director of the Downtown Association.
And then we have one call in if the caller can introduce themselves. Maybe not. Well, we'll go ahead and move forward. Again, thank you very much for the KVH team joining the Chamber of Commerce. With us is Julie Peterson on the left-hand side. Then we have Carrie Barr, Dr. Martin, and then Mandy Olson. Thank you very much for joining us. The way that we usually do this process is we leave it for you guys to give us an update, and then we did have an ability for questions to be asked prior to this call, and so we'll go through those questions, and then Julie, I'm assuming you'll let us know who will answer those questions for us in this update.
Okay, wonderful. Again, my name is Julie Peterson. I'm the CEO at Kittitas Valley Healthcare. And just for a little bit of background, in addition to Hospital District 1, which is down here in Ellensburg in Lower County, we also operate Hospital District 2, which is Medic 1 up in Upper County. So when you hit Snoqualmie Pass and until you get to the Columbia River, you really are in the care of Hospital Districts 1 and 2 in Kittitas Valley Healthcare. So my role as CEO, Carrie Barr runs all of our clinics. So up in Cle Elum, she has family medicine Cle Elum, and she has all of our specialty and primary care clinics here. Kevin Martin is our Chief Medical Officer. In addition to that, Kevin also still works in the clinic, still sees patients when he can, and is also the medical leader of our community outreach, so our home health hospice program. And Mandy Olson runs our risk management, infection control, quality. So between those two, Mandy Olson and Kevin Martin, they've really been the clinical leads on our approach to this coronavirus and COVID-19. So we've implemented, and Michelle will probably have this date off the top of her head when we opened Incident Command.
March 2nd.
March 2nd, Kittitas Valley Healthcare opened our Incident Command and essentially identified this as a process that the entire healthcare delivery system, as well as EOC, obviously the entire community was going to be involved in dealing with this public health emergency, this public health situation for a while. So we assembled our materials management people, our facilities people. We have worked extraordinarily closely with public health through all of this, and I think because of that, KVH really has been able to respond. We've been, I don't think that I'm inaccurate saying that we have been a step ahead of most healthcare facilities in our response. We were ready with our surge plan. And the cooperation, the partnerships, again, all the partnerships between the EOC, public health, the hospital district, everyone that's been involved with this has just been amazing. So we come to today, we have just in the last few days received interpretive guidance from the governor's office that has allowed us to begin scheduling surgeries again. So back in March, we canceled all of our scheduled surgeries. And that was not because of the infection itself. That was in preparation for surge. So at the same time we were identifying this wave of disease in Washington State, we were also identifying the fact that we were probably over-reliant on the Chinese market for our personal protective equipment, or PPE, and we were confronted as a state and now as a country with PPE shortages. So we stopped seeing non-emergent patients in order to preserve that PPE and prepare the organization for surge. So over the last 6 or 8 weeks, I would say, we have spent our energy. We have found out just exactly how important our materials management people are to us. They have identified alternative sources for a lot of that PPE. They have very creative sources in addition to the thousands of masks and gowns that the community have provided to us. So we are ready to open again. We have PPE for 30 plus days at surge capacity. Our facilities folks went through and modified the facility to provide an opportunity for us to isolate potential infected patients from patients who were not infected so that they don't cross paths. We actually have alternative entrances and exits and alternative patient paths for those people. They built doors, they built walls, they built tunnels. So facilities did an amazing amount of work, including changing all the airflows in the facility to address it. So while KVH is sort of ramping back up at this point, we do so very, very mindful of the fact that we may need to pivot back to a surge capacity situation and prepared to do that at absolutely any time. So that's kind of where we're at. The only other thing I would say before we get into specific questions is nobody at KVH is talking about getting back to normal in June or this summer. We have committed to being in this mode, being able to transition to surge, to remaining flexible through 2020. and there's no reason to think that we'll be standing down in terms of readiness before the end of this year, and we'll reassess as we get closer. So that's kind of where we're at here. Amy, did you want us to just go through the questions that we've received, or did you want to tee those up for us? Or?
I'm good either way, just so that we can make sure that we have 11 of them. So let's just make sure all of them do get asked and answered.
All right. So number one, I think we have assigned to Mandy Olson and Dr. Mark. Okay. Let me read it. Yeah.
Has COVID impacted CAUS differently than larger hospitals?
So critical access hospital, and in terms of what we have to do, bear in mind that we're ready, we were talking before we got on this call, we're prepared at any time to handle a mass casualty incident. We've gone through that within the last couple of years. We stand ready to ramp up and move patients as we need to. One of the things that is different in the preparation for this is the understanding that when we're putting out a COVID fire, it's entirely possible that everybody around us is putting out the same fire, and we may be keeping patients longer than we normally would. Critical access hospitals normally are fairly short stay, and COVID is not a short stay illness. So that's probably the biggest operational change.
I'd say, along with what you said, as you know, this is some of the work we do already, being prepared for whatever comes into our county. We're the only hospital in our county, so we have to be here for our community. There's no one else across town to ship patients to because, you know, we don't feel like it. But infection control is also a part of that. Infection control has always been a part of what we do with care for patients here. There are other infectious diseases where we have to isolate and wear PPE. The scale is different.
Where is he?
The scale is different as well as
upstairs? You wash your hands?
The challenges with PPE is different from previous situations, and having to follow different direction from the state in how we manage that.
But that isn't unique to us. Every hospital in the state is using, we're all together conserving PPE as best we can and trying to have the same conservation measures in place across the state.
And one of the themes that I will go back to is relationships, and our ability to respond as effectively as we have has a lot to do with those relationships. And you know, here in Kittitas County, our EOC has stood up, Incident Command has stood up for fires. We have multiple incidents where all of the agencies in this county have to come together, whether it's road conditions and multiple motor vehicle accidents, where all of those agencies come together, and we're very good at working across agencies and working as a team. So we have a lot of experience with that.
I'll say one other thing we talked about being critical access hospital or being small is the ability to be nimble. That some large organizations really struggle with getting the whole behemoth to make changes. And so being small means we can make changes quickly, and we really have been able to.
And to that, one of the reasons that another reason that we suspended our planned surgeries was the expectation that if we had to, we could use those rooms as patient care rooms and use the anesthesia machines as ventilators if things got tight. I think that's probably an easier decision for us to make, and to make the physical changes, putting barriers across our OR suite so that we can have one side as patient care and continue to run the other side for emergency surgeries. There's a lot of things that went on behind the scenes over the last 10 weeks, I'm told. Funny, it seems like time. But a lot of things that we were able to do that I think would have been a lot harder in a bigger hospital.
So, Julie, were there any federal or state funds available specifically for CAUS, or has anything been awarded to KVH?
So the CARES Act, in I believe it was 3.0, there were $100 billion that were identified for providers, not just hospitals, but all providers. Very rapidly, the federal government released $30 billion. That was, and both of these allocations were done essentially based on the size of the organization. But $30 billion went out to all providers. So we participated in that back in April. Then $10 billion just this week was released to rural providers, and that was federally qualified rural health clinics like Community Health of Central Washington, rural hospitals, and rural health clinics. And we have several rural health clinics associated with Kittitas Valley Healthcare. So there's, of the $100 billion that was initially identified, they have released about $50 billion of it. They are reserving some for Medicaid-dependent hospitals, like children's hospitals, and then they're also reserving dollars for hotspots. So they've just come up with a formula for hotspots. So that hasn't so far been a rural thing. But yeah, in both April and May, we received funding from that CARES Act.
Great. Dr. Martin or Carrie, can you talk a little bit about the impact this has had on our healthcare providers?
Yeah, do you want me to, sorry, do you want to go ahead?
Go ahead.
Okay, so yes, this has had an impact. I mean, this is, to Mandy's point, we're nimble, we're a smaller hospital, and with that, we've been able to pivot pretty quickly with how to provide care. Telehealth has been one of those methods, also using telephone, but this has not been uncommon for a rural community to be able to shift. Now, Julie had mentioned that on March 2nd, we had started Incident Command. The other piece that happened shortly after that, on March 2nd, we started Incident Command. On March 6th, we opened up our COVID clinic where our providers were then, March 7th, sorry, off a day. And we were able to, our providers were able to go there and assist not only Monday through Friday, but also on the weekend. So these are the types of providers we have in our community. They're willing to help out wherever. There is a strain. I think there's a strain on all of us, right, in terms of the community, and our providers feel that for sure. And I think primarily the strain is they miss seeing their patients face to face and connecting with them personally.
And I'd just add that as part of our surge planning, our providers, we're prepared for the possibility that our existing team of hospitalists essentially becomes our COVID care team and taking care of our patients in intensive care. Other providers who have hospital experience have been retraining, relearning the skills that they haven't used for a while and are prepared to take care of the less acute patients, because I don't think we'll be lucky enough to have people stop having strokes when we're in the middle of an outbreak. We're still going to have people that need to be hospitalized. We haven't had the kind of strain that a lot of our colleagues across the country have had, simply because we haven't had to deal really with an outbreak here. But 10 weeks of preparation and readiness is a long time to stay at battle stations. And there is a strain associated with that, but we're ready.
So and to that, when we stood down our elective surgeries or our scheduled surgeries, that freed up a lot of our other clinical staff besides providers, our nurses and the folks who worked in the OR. And they very quickly reassigned to the emergency department to help with surge planning in the emergency department. They were back in critical care and med surge, again, familiarizing themselves with those skills. Some of them hadn't worked back there in a few years. So rather than furloughing the staff and sending them home, we were able to retrain them, redeploy them to different departments. And now that we're starting surgery again, it really has been just extraordinarily seamless.
So talking about starting surgeries again, what's the community response been to reopening that process? We didn't close the clinics, but welcoming them back in. Can you talk about that a little bit, Carrie?
Yeah, I can. It's been a positive response. Obviously, folks who have had a delayed surgery are incredibly excited to get back onto the scheduling books. I think more excited than we've been taking a very slow, measured approach, and so we're making sure that we're not booking out too far, because that's the last thing that we would want to do is promise someone they're going to get a surgery in July or August and then have to pull back from that. And when I say a measured approach, this is all around making sure that we have all the right resources and we're doing all the right testing. And the people we've had at the table, it's been an incredibly collaborative approach with Dr. Larson's input, of course, our Chief Medical Officer, Dr. Martin. We've had the surgeons at the table, and we've had our nursing staff at the table as well, just to make sure that everybody felt that we had a good plan in place.
And can I I always find myself adding to everything. We, here at KVH, we work with the Washington State Nurses Association as well as the Teamsters. And again, this has been a great collaborative venture with them. WSNA was at the table. We want to make sure, because personal protective equipment has been such a critical issue, we want our union partners to know that we are operating in a safe manner with regard to our staff, not just our patients, but our staff. So we very deliberately have had those bargaining units at the table every step of the way with us, so that as we brought patients back into the facility, everyone felt we were doing the best thing for the community, the patients, the staff.
So talking about safety, I'm kind of throwing this one in, Amy. But can you talk about, Dr. Martin talked a little bit about the safety measures in the hospital on the cohorting of patients. Can you talk about what's happening on the clinic and why people should feel comfortable coming back in?
Sure, yeah, and I think we touched a little bit on this in a newspaper article, but you know I can never stop talking about clinics, so I'd be happy to just ram around, keep chatting about that. So we, much like what you'd see in the grocery stores, we of course have our social distancing. We were doing that prior to it being a fad, and so we removed chairs from the waiting room to make sure that folks weren't sitting next to each other. Every day was a constant change and a constant adjustment to the plan, because it went from that to we had patients in their car. We would call them to check them in. We were rerouting patients to come into different areas of the clinic, separating the well versus the ill. Started doing a lot of parking lot care, so going out to the parking lot to provide childhood vaccinations and some other testing that would happen, again, in the parking lot.
I think our pediatricians have gotten kind of used to being able to give those vaccinations in car seats. I'm not sure going back to squirming kids is going to be, so we may see that as a permanent change.
It may be a change, yeah.
Awesome.
Just to the point about social distancing, 11 weeks ago, this conference room held 15. And now we get a little squirmy if there's 5 of us in here.
Yeah.
Yeah, exactly. So let's go back to finances. Julie, do you anticipate any Washington State rural hospital closures due to COVID, or do you know any of that have closed?
So we have been incredibly transparent with our staff here as we discussed what the financial impact of this was on the hospital. When the governor issued his stay-at-home order, that coupled with the requirement that we stop scheduling surgeries, in April, that reduced our revenues by about $1.8 million. So in the month of April, we lost $800,000. March, excuse me, that was March. In the month of April, we are down about $6.5 million over what we would have anticipated in terms of charges. So we are going to lose in the month of April probably $3 million. Now, we have received some of those federal funds that came through, but the conversation with our staff we've been very clear that this is not sustainable. That being said, KVH is in a much better position than most hospitals, not just community hospitals, not just rural hospitals, but we are benefiting from very conservative stewardship over the last 40 years. So we have a very strong balance sheet. And we went into this with cash in the bank. We immediately turned to a local bank who understood the situation and provided a line of credit for us in case we needed that. So KVH will come through this, and we are in this, again, this is a long game as far as we're concerned. But we are going to end April with probably somewhere near $4 million in losses for the year. And understand, we went into 2020 looking at a very, very strong year. KVH is much more fortunate than most hospitals, and certainly more fortunate than most rural hospitals. Going into this pandemic, there were 12 rural hospitals that had less than 30 days cash on hand. So they could maybe make payroll and maybe make 2 payrolls at the most. So rural healthcare has been, particularly the smallest rural healthcare providers, have been in trouble for a long time, and this certainly didn't help. There are a couple larger rural hospitals over on the west side that were also very much struggling before this started. So if you'd asked me if every rural hospital in the state was going to be open at the end of 2020, before all this started, I would have said no. I think there were a couple that were really on the bubble. Right now, there's been a cash infusion for these hospitals through the CARES Act, but that money's going to go very quickly. So this is not sustainable, and if we don't figure out a way to get hospitals back to doing what they should be doing at 100%, then yes, we will lose rural hospitals. Some of those rural hospitals were already just struggling to stay open day to day. So.
Do you anticipate any increases in call reimbursements due to COVID?
No, we don't. At the end of the day, we're going to go back to where we were.
Actually thinking about some of the conversations we've had about FEMA money and a lot of the preparations we've done, the time that we've been keeping track of the time that we put in on all of the preparations we've done. And when this is all over, it'll be submitted as a cost report, and we hope to get 70% of what we've spent.
Last thing on the financial side, does the closure of CWU have, with the students not being on site, does that have a financial impact on KVH?
Those are young healthies, so we see less of the students than they represent in terms of the population. So we feel it when they come back into town, but that noise has certainly been lost in the larger disruption.
Not yet. So during the peak of COVID, what were the volumes like on our inpatient census? Did we see an increase there?
No, we did not see an increase in the inpatient. We actually saw a significant decrease in inpatient. And I'm sure Mandy can talk to the hospital side, but specifically in the clinic side, it's not uncommon to see 350 patients on average, on a daily average in our clinics. And it was, we were down to about 100 patients at one point on a daily average. So that's significant. I think there's the message there that we really need to focus on is just shifting from illness to wellness, and how important it is for our community to maintain their wellness and to not be afraid to come in and see their providers, that we have the safety measures in place. And so to the inpatient side, I don't know if you had something to add, or if Dr. Martin had something.
Yeah, that wasn't a phenomenon that was limited to KVH. Nationally, communities that didn't have COVID saw a decrease in clinic visits, a decrease in emergency department visits, and a decrease in admissions. And the people that did come in were coming in sicker. So you weren't seeing somebody coming in with chest pain that started an hour ago. You were seeing somebody that had had their heart attack 2 days ago, or had broken their foot 2 days ago, or had had a fever for several days. Anecdotally, the folks at Virginia Mason Memorial feel that they saw an upturn in patients coming into the emergency room with a ruptured appendix. Rather than coming in when it started hurting, they waited until they got really sick and wound up needing more hospital care as a result.
The other thing I'd say about the hospital, I don't think people realize this out in the community, but we have taken care of a lot of people who have been suspected to have coronavirus, but we've actually not had a single inpatient in our hospital that was positive coronavirus. Yes, Michelle's knocking on wood, right. So we have, we've taken care and tested a lot of people, but I thought that question was interesting, just even saying during peak COVID, because as you know, here in Kittitas County, I mean, that was like, I think one day we had 3 positives in the county. I don't know if I'd call that a peak.
I would just, I guess my take on that would be, ask us when we see our peak, because we aren't there yet.
Right, yeah. So we've been very fortunate.
So I think we've been fortunate, but I think we also have the benefit of being in a community and in a county that has responded quickly and responsibly to this entire pandemic. And the COVID clinic, and Carrie didn't take enough credit for that, by having that facility there 7 days a week, we could always tell people, on some days they answered hundreds of phone calls. We had 5, 6 people answering the phone there, just reassuring people that they could stay home, monitor their symptoms. We would be there 7 days a week if they needed us, if they needed to come in. What they weren't doing was going to their primary care provider and sitting in a waiting room with a bunch of other patients or coming into the emergency department. So we actually had them in a location that was specific for COVID. Again, we had folks we talked to a couple of times a day who would call. We'd say, you know, if you need to come in, do. But if your symptoms get better or get worse, we'll be here the next day. So having the luxury of having that facility and the staff who was willing to go in 7 days a week to take care of patients and to talk to the worried well on the phone, I think went a long way towards keeping our community disciplined and keeping those numbers down.
Well, I asked real quick to interrupt this. So usually we're well off onto the questions. So those that are participating, thank you for joining us on the call today. We do have the chat function on the side. If you do have a question based on some of the discussion that's being had, go ahead and send that question, and then Michelle and I can either go through that together, because I know sometimes conversation does bring another question up. So feel free to use the chat function to ask your questions if something comes up, and then we'll continue with the pre-questions, and then if we have some in the chat, we'll go to those questions. But thank you.
Thanks, Amy. So back to the clinics a little bit. Carrie, can you talk a little bit more about the role telehealth has played in the patient care during this time, and what type of future that may or may not hold?
Yeah, so I touched on that a little bit before in terms of having to adjust quickly on how we provide care in the clinics, and telehealth was one of those methods we had to adjust quickly, and it could not have been done without the incredible team, our IT information systems team that just came together, made sure we had all the equipment, all the training, the Zoom platform that was HIPAA compliant, to be able to have those conversations with patients. We've conducted over 700 telehealth visits, and primarily the front runner of that are some of our demographics that are surprising, and that's just some of our older demographic patients that have been able to adapt really quickly to this and saying, hey, this is my first time on Zoom, and I'm able to see my provider. And some of the things that the providers are noticing, and Dr. Martin can talk about this, is it's like a home visit. You can actually see their environment, see how they're living, see if they have pets, if they're, you can just really see see a lot more than what you could normally. In terms of the longevity of it all, I'll go back to my point of our providers are incredibly, they're missing our patients, as well as we're seeing now patients are starting to come back to the clinic because either they have issues that require to have face-to-face appointments, or B, they just truly need that social interaction as well. And I don't know if you had something, Dr. Martin, to add.
It's going to be interesting because there is a lot of opportunity in telehealth. There's also, I think it's something that may work against rural health in a lot of ways, surprisingly. It offers an opportunity for big plans and big systems to essentially have the farm in South Dakota with a bunch of docs in it on the phones and in cubicles. And some plans may say you can see your doctor in Cle Elum and have a $30 copay, or you can pick up your smartphone and talk to somebody in Lower Albonia for free. And some folks will take that option. But I do think it also offers us an opportunity. I'm lucky, I do a lot of hospice work, which means I'm in a lot of people's homes. And it is an insight that you cannot get in the exam room. You don't understand the challenges some people have or the strength that some people have until you see them in their own environment.
So Leslie from up in Upper County, I believe in the horse park, was asking about if someone visiting the area isn't feeling well or has symptoms, what would we recommend they do?
If they're up in Upper County, I would recommend they go to urgent care. Urgent care can do COVID testing, or after interviewing and talking with the patient, they may send them down to the COVID clinic. But if they don't have established primary care in the county, I would send them to urgent care in Upper County.
One of the concerns that we have as a county, as we ask for a variance to move directly to phase 2 of reopening Washington, is if we have opportunities for people to eat out, to have recreational activities that aren't available to them in their communities, does that create risk for us? And the answer is yes. And that's one of the things that we have to be prepared to respond to. But we have to be mindful of that. The Board of Commissioners, when they were debating applying for the variance, half sincerely discussed whether or not there was a way to put gates on I-90 and I-82. So I'll tell you that the scenario you describe is one that gives me pause.
But that being said, we provide care.
Yeah.
So if somebody shows up at one of our facilities, we take care of them. That's what we do, regardless of what their zip code is. And we have had patients that have come to our coronavirus clinic because they didn't feel they could get taken care of wherever they are right now. So, and we've taken care of them.
In fact, 2 of our early positives that were originally attributed to the county were actually King County residents who came over here to get tested because they couldn't get tested where they were.
It's been a really interesting phenomenon also, as we've seen our providers in Kittitas County get very protective of their patients, because when you send them out of Kittitas County, you're sending them pretty much invariably into an environment with a much higher instance of disease. So it's like, to the degree that we can keep people in an environment that we can manage, I think our providers are feeling like Kittitas Valley, Kittitas County is the place to do that. So
touching on that, out of county and things like that, and going back to safety, we are surrounded as a county by higher numbers, and we have visitors and employees coming from that county. We talk about how we care for visitors. What about the protections we're taking for staff that are coming in? Mandy, can you talk about the infection control, the employee monitoring?
Yeah, so CDC and DOH both recommend that anytime a staff person sets foot in a healthcare facility that they have their face covered now. That depends on their role, and if they need medical masks or respirators, they should be using those, but for our non-clinical folks, that could be a cloth face covering or a face shield or other things. So that's one of the ways. It doesn't just protect our staff from each other, it also protects our patients from our staff too. So that's one way. I mean, as much as is available to us organizationally, and not just for people who work out of the county, but staff are encouraged to work from home. We have Zoom meetings to stay home when they're ill. And we have all of our staff monitoring their temperature and for symptoms before they come to work. We have thermometers available to them here as well as tracking logs, but we ask people to do that before they show up here so that we're not waiting till they've already walked through the building to determine that they need to go home. Did I touch on?
That's great. So throughout all of this, what did we learn about the actual building's ability to respond to COVID? Is there anything about this facility that which should be changed to better position us should this ever happen again?
So what I learned is our facilities folks are magical.
That's exactly the point I was going to make. We, in the space of about a week, were able to convert essentially all of our patient care spaces into what are called negative pressure spaces, meaning that air is drawn into the room by the air handler rather than being pumped into the room. And what that does is if there's infection in the room, it pulls clean air in and exhausts it outside the building. I had no idea what would be involved. We had, I think, a couple rooms in the emergency department and one patient care room that were negative pressure 11 weeks ago, and now essentially the entire facility is negative pressure. If you had told me that we could do that without tearing the roof off the place, I wouldn't have believed it, but we did it. Our ability to, I mentioned earlier that we've separated our operating suite with a partition so that if we do need to use two of our operating rooms as patient care rooms, we can do that in a way that protects the third operating room. That we considered it, decided to do it, and it was done in a day and a half, I think. It's been remarkable. Some of you who drive by the building, the two external changes you'll see are the tent out in the parking lot. If we start seeing COVID cases, that's where people will get sorted as to which entrance they use. And on the back of the building, there's a wooden tunnel that goes to the back operating room so that we can bring patients in there without taking them through an area that's potentially contaminated with coronavirus.
I think going forward, I'm going to have much higher expectations of my facility staff than we did in the past. They set a high bar.
We have dubbed our facilities chief the Wizard of Wind.
Yeah, there you go.
So the last question that we had before this got us all thinking. If you had to COVID do-over, other than being in Hawaii when it hit or Fiji,
early retirement?
What would we do different?
Not a thing. I said earlier, I'll jump in, because I said earlier that every single person at this table and then the rest of the admin team that are not present right now, we were all on different calls, whether they were regional calls, local calls, national calls, and every single one of us we're on this representing our organization, trying to figure out what the best route was, how to implement this, how to do that, and we would come together in incident command to discuss the results. And the majority of the time it was, well, I didn't learn anything. Matter of fact, we're ahead of the schedule. We're ahead of the curve. We're doing, and I'm not saying that just to, well, I am saying it to brag, but I mean, it really is. It's the truth, and I think it's something as a community member, just a swelling amount of pride that I had of an organization and the hospital knowing that it's responding so quickly to a global pandemic that we didn't plan for, nobody planned for it, but that we were sharp enough to continually adjust to every curveball that was thrown at us.
And the community did it with us.
And the community did it with us, absolutely.
Well, and that's a good opportunity to say thank you to everyone for the support we felt. It's been truly humbling, and it makes it easy to come to work.
Well, I know I put on like 10 pounds. Everybody keeps feeding us, and yesterday we got wonderful flowers from the folks at Safeway. The outpouring of support, the masks. And if anybody ever heard out there that we had enough masks and we didn't need more masks, that's absolutely not the case. So just an incredible amount of support. I would say if I had one thing to do over, it was towards the end of March that we really identified that we have 650 people. This is a complicated message. They're complicated rules, it's hard for people, and it's very stressful. And it wasn't until about the end of March that we began using our 650 employees to help us communicate a complicated message to the community. So Mandy would walk people through what the latest information and guidance from the CDC was, and it would change the following week. And we would go back to our employees and say, here's what you need to take home to your family, your friends, have your spouse talk to their coworkers. This is the latest information we have. So we've really mobilized 650 people to help us educate and mobilize the community to help keep our numbers down and keep us safe. And that would be the one thing I think I pulled the trigger on, that kind of communication with our staff earlier than we did. So
the thing that I think is going to change in terms of how we deliver healthcare is, I think we were having troubles with sterile gowns from China. There was a huge recall at the end of last year because of a contamination issue, and then having a pandemic on the heels of that exposed the weaknesses in our supply chain. I think we will be looking at ways to protect, at PPE that is more durable, that isn't considered single-use disposable. You've heard a lot about N95 masks, and now when we have conversations about N95s at the state level, we talk in terms of tens of millions of units. And it's probably more realistic to think about things that can be used for a longer period, sanitized and reused. So we'll probably be looking at more, not getting too technical, things like that are called pappers and cappers. But having said that, I'm hearing that there's now a shortage of the disposable components of those statewide. So I think in terms of economics over the last 20, 30 years, there's been a real push for efficiency in healthcare and being able to do things with just-in-time inventory and all kinds of great wisdom that we got from the auto industry. And I think what we may have learned is that preparedness, it can be the victim of efficiency. To the extent that we're keeping as little inventory on hand as possible, it means that we're more challenged with dealing with a surge. And that's a policy issue that's going to be debated nationally when the dust settles.
well, and we've been chasing inpatient beds out of the system for the last 35 years, and that is why we're trying to flatten the curve, because we don't have that inpatient critical care capacity that we did 40 years ago. Everything that can possibly be done on an outpatient basis is done on an outpatient basis or 23 hours. So our inpatient facilities have dwindled over time.
It would be interesting, and I haven't looked at it, but Denmark very aggressively did that and essentially decommissioned 2/3 of their inpatient beds over the course of 10 years. And it would be interesting to see what their surge capacity looks like when stuff gets real.
So
I just want to, just real quickly, last month, so mid-April, Vice Admiral Bono came here for a tour and couldn't say enough great things about what we had done in preparation. And there was no press on that. Matter of fact, that was one of the requests on her, just not to be distracted. She wanted to go to these rural areas and not be distracted with a lot of press. So not a lot of folks knew that she was here, but one of the decisions made from that, based on what she saw here and the preparation that we had conducted here in the preparation in the surrounding communities, was not to stand up a hospital in Yakima. So I think, again, that says a lot about the hospital that in your community, and all of you as community members.
So Amy, did we cover everything?
You did. Thank you very much. It was very seamless, and we appreciate that. And so again, thank you to those participants. We have about 10 minutes left in the hour that we've given. So if you do have some questions, go ahead and use the chat field just for the last minute questions. But you know, Julie, your team that has joined us, we really appreciate you taking the time and answering the questions that we put forth to you. I think it's kind of ironic that we're doing this on National Nurses Day. So we want to express from the Chamber of Commerce, thank you very much for your thorough process and operations, and especially keeping our health and our ongoing health in mind. So kudos to you, your team, and the first responders and all of those at the front line. We really appreciate everything that you do. Thank you very much.
Thank you for that. And it is an amazing team, and they came together seamlessly, and somewhere early on in this emerged the tagline that we've got this, and we do. And when we say we've got this, we look at each other and go, yep, we do, we've got this. So
that's
pretty
awesome.
It is, it's fabulous. So.
Well, I didn't see any questions come up during that time, so thank you again for all those that have joined us on this call. We appreciate it, and we'll be announcing our next week's sessions. We hope that this is helpful for you to at least be up to date and understanding where KVH is in this process and moving forward in the future. Thank you again, you guys. Appreciate it. Have a great day.
Thank you, everyone.
Thanks very much.